Good evening, everybody. My name is Patrick Messerschmitt. Thank you for joining. I'm one of the hand and upper extremity surgeons here at OrthoCincy, and we're going to get started with our presentation. This webinar is supported with our partners at the Christ Hospital, who opened a very nice joint and spine center, orthopedically run back in 2015. They have beautiful facilities. I perform approximately half of my surgeries down at their facilities. Just a little housekeeping here. You're all muted. Please type any questions or comments in the chat box. We'll get to those at the end of the presentation here in a few minutes. This is being recorded, so you'll receive a follow-up email with a link if you would like to watch it again. No disclosures. And again, Patrick Messerschmitt, I'm a local product, having grown up on the east side of Cincinnati before heading off to Ohio State before college, and then I came home to UC, or University of Cincinnati, for medical school before finishing up my surgical training up in Rhode Island at Brown University. So tonight's focus is on some very common ailments that present to my office. Those include carpal tunnel syndrome, cubital tunnel syndrome, and tendonitis of the hand and wrist. So first off, carpal tunnel syndrome. This occurs when there's a compression of the median nerve at the wrist. It's the most common entrapment compression of the nerve in the upper extremity, or pinch of the nerve in the upper extremity. Unfortunately, early stages of this ailment are reversible with treatment. In early stages of carpal tunnel syndrome, the compression of the nerve at the wrist actually restricts the blood flow. So the blood flow is decreased down the nerve as it goes through the tunnel. This can lead to dysfunction of the nerve that will lead to numbness or tingling in the hand. This is created by swelling of the nerve, and fortunately, treatment of the early stages yields excellent or good results for patients. More long-standing carpal tunnel syndrome leads to myelin damage or damage of the sheath of the nerve. That leads to slowing of the conduction or the firing of the nerve down the arm to the hand. And this can eventually lead to the axons getting very unhealthy and dying. At that stage, typically reversal of the nerve damage is not possible. Carpal tunnel syndrome is very common. Over 1 million people are diagnosed in the United States each year, and more than 4,000 carpal tunnel releases are performed in the United States. Fortunately, in the right setting, reversal of carpal tunnel syndrome is very good, or has good outcomes after surgery. So carpal tunnel syndrome, what you may feel is pain in the hand or forearm. You may feel numbness or tingling in the hand. This will be on the palm side of the hand, such as the thumb, the index, or the middle finger. Symptoms can typically be worse at night. Patients will wake up with painful hand or numb hand. It may even keep you up all night. These symptoms can be aggravated with repetitive use or job activities with the hand. Risk factors for carpal tunnel syndrome. Well, first of all, there would be an anatomic reason. So the size of the carpal tunnel may actually be decreased, which can happen from arthritis or other bone lesions. Or alternatively, the contents within the carpal tunnel can be enlarged, such as a tumor, an abnormal muscle, or potentially swollen tendons, leading to increased pressure on the median nerve. So this is an interesting case that presented to my office. This patient lives locally. She came in complaining of numbness and tingling in the hand. Workup revealed carpal tunnel syndrome and a mass within the carpal tunnel. And this is a surgery that me and my team performed here locally, removing this benign tumor from within the carpal tunnel, which led to resolution of her symptoms. So risk factors also include diabetes or rheumatoid arthritis, or other ailments that may lead to fluid imbalance, one of which could be pregnancy. Occupational or athletic participation. Risk factors for carpal tunnel syndrome would include repetitive use of the hands and wrists. I see this in mechanics or machinists. I also see this in patients utilizing vibration instruments such as jackhammers. It can also be common in prolonged bicycle use, which will cause pressure on the nerve at the carpal tunnel, once again decreasing the blood flow, which will lead to pain, numbness of the fingers. On physical exam, we're looking for any muscle loss that typically will occur at the base of the thumb, and that typically is coinciding with more advanced disease. We'll perform tests on the hands and wrists trying to exacerbate or recreate your symptoms of numbness or tingling. That would include the Fallon's test or Tinel's test. Very helpful is nerve testing. This is a simple test that will send a signal down your nerve to the hand, and that'll measure the speed of the nerve. It'll let us verify if there's compression and where that compression is, whether it be at your wrist or potentially at the elbow or neck. And it can also grade the severity if it's a mild compression or severe. Non-surgical measures for carpal tunnel syndrome. That's always our first step. That would entail activity modifications, avoiding those activities that aggravate your symptoms. We can try splinting the wrist at night, keeping the wrist in a more extended position rather than flexed, which can pinch off the carpal tunnel and decrease blood flow to the nerve. We can try anti-inflammatories or oral steroids. Carpal tunnel injection can decrease the swelling or inflammation around the nerve and may temporarily or for quite some time improve symptoms. Some patients like to try alternative therapies such as vitamin supplementation or acupuncture. Non-surgical measures are typically successful in those patients with more milder disease or with symptoms that have been only lasting for a few months. Typically, non-surgical measures are unsuccessful in advanced disease or muscle loss. So surgical management, it's pretty straightforward. We make a small incision in the palm, and the transverse carpal tunnel ligament is the structure that's actually causing the compression of the nerve. That is released longitudinally. It opens up and the nerve will be relieved of that pressure. Studies have shown that the carpal tunnel volume can increase up to 24%. This can be done by a small mini open procedure or with an endoscopic procedure, which utilizes the aid of a camera. So open carpal tunnel release is my choice or preference. I perform a mini incision, which is seen on the diagram at the bottom and on the right, with a small incision longitudinally in the mid palm. This allows direct visualization of the nerve for safe release of the nerve. The downfall of this is the palm may be sensitive for a few weeks or even a few months following surgery. This is a patient of mine that presented to office. His nerve test is on the left side of the screen. The motor function of the nerve is slowed. As you can see, the speed should be less than 4.0 milliseconds, and he was measured at 4.4 milliseconds. The sensory function of the nerve was non-recordable, meaning that the signal was so slow coming through the carpal tunnel that it was difficult to pick up on the nerve test. The patient was not improving with non-surgical measures, so we elected for surgery. And the diagram on the right side is his incision approximately 10 days after surgery, showing a small 2-stitch incision. The patient did quite well and all symptoms resolved. Outcomes in general for carpal tunnel syndrome surgery or carpal tunnel release are good or excellent, more than 95%. And overall, the results between open and endoscopic techniques are similar. One last comment there would be, if you like your doctor or like your surgeon, I would go with the procedure that he or she is comfortable with, because that's probably going to lead to a better outcome. Cubital tunnel syndrome, that's the ulnar nerve compression at the elbow, second most common nerve entrapment of the upper extremity. It occurs on the medial side of the elbow. There's several sites that as physicians we need to be aware of that the nerve can be compressed. This can be caused following a fracture with an angulation of the bone. Patients can present with abnormal muscles within the cubital tunnel pressing on the nerve. Tumor growth can cause this also, or subluxating nerve is actually not an uncommon phenomenon that we see, which occurs when the elbow is flexed and extended. The nerve will snap about the elbow or the medial epicondyle, the bone on the inside of the elbow, causing ulnar nerve symptoms. Patients with cubital tunnel syndrome may feel numbness and tingling of both the ring and small finger. There can also be pain up the inside of the forearm to the medial or inside of the elbow. Loss of finger strength or dexterity is common. And as you see in the picture below, patients can get clawing of the ring or small finger, which is Benedictine sign, or they can get loss of the muscles between the thumb and the index finger. That's typically in a more advanced disease. On exam in office, we'll perform a Tinel's test, and that's some tapping along the nerve at the medial elbow. That's hoping to recreate any discomfort or tingling down the arm. We'll flex and extend the elbow to assess for any subluxation or snapping of the nerve over the bone. Once again, helpful is a nerve test. The nerve test will confirm whether or not there's slowing at the nerve at the elbow, make sure it's not coming from the patient's neck or wrist. It'll also help us grade the severity of the compression being mild, moderate, or severe. Non-surgical treatment is our mainstay, our first course of action, and that would include modifying your activities. You want to avoid repetitive elbow flexion at prolonged periods, such as holding a telephone with your arm or elbow flexed. You want to avoid extended pressure on the inside of the elbow, such as long car or truck rides with the inside of your right arm on the console. Nighttime bracing is aimed at keeping the elbow in a more straight position, so the nerve has an open position of the cubital tunnel, which will allow increased blood flow. Oral anti-inflammatories or oral steroids can be helpful. In general, cortisone injections about the cubital tunnel are not common and can be ineffective. Surgical intervention for cubital tunnel syndrome is typically reserved for those who have failed non-operative measures for 3 to 6 months. However, if we see in office the patient has muscle wasting or significant muscle weakness or dense sensory loss, we may consider early surgical intervention. Once again, similar to the carpal tunnel syndrome, cubital tunnel syndrome is simply taking the pressure off of the nerve, which will then increase the blood flow and increase function of the nerve. My procedure of choice is an open in situ decompression, meaning open, release the nerve carefully, visualize all the structures, but leave the nerve in its natural place. So the blood supply of the nerve is not disrupted. We release all sites of compression as seen in the diagram on the bottom right. And then the elbow is moved during surgery, flexed and extended. And if the nerve is stable, the wound would be closed and the nerve would not have to be moved. Endoscopic release can be performed with aid of a camera. This utilizes a small incision. This is deemed not safe if preoperatively we feel that the nerve is mobile or subluxating, because that increases the risk of nerve damage during the procedure. Subcutaneous transposition, as you can see in this picture, the nerve has now been moved up and over the bony structure, so that's a nerve that is unstable. It does require a larger incision to do this safely. It does require the nerve to be carefully moved over the bone. We then utilize a small strap or strip of fascia or tissue to prevent the nerve from snapping back beneath the bone after surgery. Outcomes for cubital tunnel syndrome, once again, are very good. Success rate is more than 90% for mild cases. As the disease is more severe when presenting to office, the surgical or final outcome can be lessened if there's been permanent nerve damage from long-standing disease. Fortunately, once again, the various types of surgery for this syndrome have similar outcomes, and once again, typically in best hands by the comfort or how your surgeon was trained is where your best outcome will be. One thing to keep in mind is that if the nerve is unstable after release, it's very important to move the nerve because the compression may be relieved from the nerve, but the snapping of the nerve will cause irritation of the nerve. So once again, if the nerve is unstable after release, it's very important to perform a transposition of the nerve to give it a stable position. And our last topic here is tendonitis of the hand and wrist. Very common in my office, especially this time of year with spring and all the home remodeling and yard projects going on. So tendonitis is inflammation of the tendons and the sheath or tube that the tendons glide within. This can happen on the flexor tendons or the extensor tendons. Causes can be occupational, such as repetitive use at work. They can be direct injury to the hand. A crush injury to the hand can cause swelling around the tendon, which causes a painful motion of the tendon up and down through the sheath. Those occupational or jobs that have the highest risk would be, once again, our patients that are doing a lot of repetitive gripping and lifting at work, mechanics, machinists, etc. So with tendonitis of the hand, that's an inflammatory process that's occurring, and in the early stage, there's pain and swelling over the tendon. So as the tendon moves up and down through the hand, it's a size problem that the tendon has a difficulty moving through the sheath. It causes friction, and this will cause you to feel pain, maybe even some stiffness of the hand. Unfortunately, in late stages, there's a lot of scarring or fibrosis, and motion can be exceptionally restricted. So the two most common tendonitis presentations in my office would be de Quervain's and trigger finger. De Quervain syndrome is tendonitis of the two tendons on the radial side or the thumb side of your wrist. It's aggravated with motion of the wrist from side to side or with use of the thumb. Finkelstein maneuver is a very common test that you would see us perform in office, and this incorporates holding the thumb within the fist and then moving the wrist from side to side and see if that recreates or aggravates your pain. Non-surgical treatment is typically very effective for this tendonitis. Approximately 90% of patients will improve without surgery. I like to use a thumb spica splint like the picture on the right that fully immobilizes the thumb. We like to use oral anti-inflammatories and may use a cortisone injection, which can decrease the swelling around the tendon, allowing it to glide better in its sheath. For those patients that fail non-surgical measures, this is typically those with multiple tendon slips or potentially a separate tendon compartment. Surgery for de Quervain syndrome is very effective, very straightforward, and in general, a very easy recovery. A small incision is made directly over the tendons. We find the sensory nerve, protect that with a rounded or blunt retractor, and then carefully release the strap or the tunnel that the tendons move through. The tendons themselves are not touched or harmed. We move the thumb to make sure the tendons glide, and then the wound is closed. And the second most common, or probably the most common tendonitis in my office is trigger finger. This is a tendonitis of the flexor tendon or the front tendons that flex or bend your finger down into your palm. The tendons get swollen and they get caught on the leading edge of the A1 pulley or the first annular pulley. So again, it's a size problem. This swollen tendon, as you bend your finger down, moves up and then into the tunnel. And if the tendon doesn't fit into that tunnel very well, this will cause pain and stiffness. So in early signs are swelling, stiffness, pain with grasping. Patients will often feel a clicking or popping of the finger. Symptoms usually are worse at night. I'll even have patients state that the finger locks and keeps them up at night, or they have to unlock the finger before they can go back to sleep. The fingers can be sore in the morning, and repetitive activities aggravate this. Non-surgical measures are very effective, especially an early trigger finger. I like to splint the fingers at night for a few weeks, not during the day. I ask patients to rest and avoid activities that aggravate the finger. Oral steroids or oral anti-inflammatories are quite helpful. And a cortisone injection, as seen in the diagram at the bottom, can really decrease the swelling around the tendon and help the gliding. This is usually more effective in my non-diabetic patients. And here our last little bit here on trigger finger is for those that do not get better with conservative measures and are still problematic. We like to perform a small 2-stitch incision directly over the pulley. It's very safe, straightforward. We protect the nerves from the two sides, and the A1 pulley is released longitudinally or in line with the tendon. The tendons themselves are not touched or damaged during the procedure. We check the finger glides smoothly and the wound is closed. There's typically a quick recovery with a Band-Aid after 2 days, and very few patients need hand therapy or any significant recovery getting back to their normal activities. And that ends our presentation. I appreciate you joining us this evening, and at this time we can move over to some questions that have been presented. So one question here was, how can I prevent carpal tunnel? Well, in some cases that's hard. If a patient is developing wrist arthritis, it may be inevitable. However, maintaining health, maintaining a good diet, keeping active and exercising is important. If you start feeling early symptoms, I would recommend a wrist brace at night that can be picked up at any local grocery store or pharmacy. And certainly if symptoms persist, we would be happy to see you in office. Another question here was a patient mentioning that they stay active, they like to lift a lot of weights. Any recommendations when lifting weights? Well, I think that if the weight routine is causing problems, you might want to back off on either the frequency or the amount or heaviness of the weights. Taping the wrist and across the hand can be very effective for stabilizing the wrist during workouts. And it may be helpful to ice the wrist after a workout and brace the wrist at night. Another good question here, do PRP injections work for carpal tunnel? I have not seen good literature on that. I have actually personally never given a PRP injection for carpal tunnel. Can heredity play a role in developing carpal tunnel syndrome? I believe so. I think that the wrist canal or the carpal tunnel canal is simply smaller in some of us. Patients will come in and mention to me that the parents have had carpal tunnel release, siblings have had carpal tunnel release, and the patient's young and active, but really doesn't have any other risk factors. So yeah, I do believe that anatomy, which would be from your heredity, would be a risk factor. Can carpal tunnel come back after surgery? It can. That's very uncommon, fortunately. I will see it a few times a year. Sometimes that's from the original surgery not being a complete release. Once again, very uncommon. but there are instances where some patients form more scar than others. So the scar tissue will bind the nerve back down and the symptoms will return. In those instances, I like to retest the patients to confirm, and revision carpal tunnel surgery can have good success for patients. Another good question here. I have what I think is a trigger finger. I've never had a doctor look at it. Are there any exercises that I can do to help? There sure is. I mean, you can move each individual joint of the finger. You can move your hand and wrist a few times a day. Icing can help with the swelling. I would avoid a very firm grip, stress ball. I would avoid flexing and extending that multiple times a day for prolonged periods. That can maybe or potentially make your tendonitis or trigger finger worse. But stretching the hand and finger is helpful, especially in the morning. Can therapy prevent tendonitis? It can. I have patients that come in that are in a special situation, such as pregnancy or maybe just postpartum, they're breastfeeding, and the patients are typically trying to be very careful where they don't want to be injected with a steroid or take a steroid. And I'll refer a young mom with a bad case of tendonitis over to my hand therapy colleagues who perform a great job with hand therapy utilizing ultrasound and other modalities. Another good question. I feel like I have new weakness in my grip. Is this because of cubital tunnel syndrome? I haven't had any new trauma. It's a little difficult to say. I think that if you have weakness in the hand that is also coinciding with some pain at the inside of the elbow and numbness of the small finger or small finger and ring finger, that would be very consistent with cubital tunnel syndrome. Weakness of the hand can certainly occur in carpal tunnel syndrome also, but more commonly in cubital tunnel syndrome. I think if that persists, I'd recommend an evaluation with one of the hand colleagues here at our group. And I think that's the end of the questions. And again, we appreciate your time and joining us here for the webinar, and there'll be a copy of this presented online in the very near future for anybody who would like to watch it again. And thank you, and good night.